From the JAMA Network, this is JAMA Neurology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Neurology.
My name is Dr. Cynthia Armand, Associate Professor of Neurology at the Albert Einstein College of Medicine, Montefiore Medical Center, and JAMA Neurology web editor. Today, we're discussing a topic related to multiple sclerosis, and I have with me Dr. Anne Kerbrat, who is an Associate Professor of Neurology at the University Hospital of Rennes in Rennes, France. Dr. Anne Kerbrat, thank you so much for joining us on the podcast today.
Thank you very much. It's a real pleasure to be there today to discuss with you.
The topic of multiple sclerosis. This neurologic disease has gone through a large advancement of improvements in therapeutic options, giving hope to so many individuals living with this neurologic disease. And of course, with that question comes what happens with therapies long term and whether or not they should be discontinued or continued after a certain age. And I see that this particular question is part of your research interest, and we are discussing your work entitled High-Efficacy Therapy Discontinuation versus Continuation in Patients 50 Years or Older with Nonactive MS. Can you tell us a little bit about the background of this subject matter and what brought you to this particular interest?
Okay, so thank you for these questions. So I think that I completely agree with you that now in multiple sclerosis, we have lots of disease-modifying treatments to propose to patients with MS, especially early during the disease. And we know now, and we have lots of study on the subject, we know that we have to start very early these kinds of treatments in order to prevent disability progression in MS patients. But now that we have these kinds of treatments, and especially high-efficacy therapy, we have the questions, when can we stop these kinds of treatments, and is it possible to stop these kinds of treatments when the patients get older? Also because you will have an increase of side effects when patients aged with these kinds of treatments.
And I wanted to ask this question because you are discussing high efficacy treatments, and I know there are medium efficacy treatments. Can you tell us a little bit about the randomized control trial, Discontinuation of Disease Modifying Therapies in Multiple Sclerosis?
Yes, of course. So it's a very interesting trial. It was performed by John Corboy. I think he's from Denver. And it's the first randomized trial on the subject. But the patients, including in these trials, were mainly on medium efficacy therapies. And he demonstrated that in patients older than 55 with a stable multiple sclerosis for more than 5 years, you can probably discontinue this kind of medium efficacy therapies with no increase in the relapse rates after the discontinuation, but with a small increase of the number of new MRI lesions.
I see. And so that's after 5 years of disease stability, no less than that.
No less than that, and it was in the inclusion criteria of these randomized trials, yes.
Mm-hmm. And based on the results of that trial, how can you relate that to your work currently? And we might as well move into what you're setting out to do.
I think this work is complementary to the work performed by John Corboy in these DISCOMS trials, because he only including, I think it's less than 10% of patients with MS with high efficacy therapies in this randomized trial. So it's very difficult to have some definite conclusions in these subpopulations. But I think also that nowadays in patients with MS, we prescribe more and more high efficacy therapies. So we really need to know what to do with these kinds of treatments. And clearly, it's a very different question to stop high efficacy therapies compared to medium efficacy therapies. Also because we know that in younger patients, when you stop these kinds of treatments, at least with fingolimod and natalizumab, you will have a risk of recurrence of disease activity.
Right. Right. Let's get into your study design and what you look to compare, because I think there's some discussion there about why individuals may relapse after discontinuation or not. So let's get into your study.
So we performed a cohort study. It's an observational study, and we matched the patients retrospectively to have some groups that we can compare. And we included patients, and we selected the patients from the French national database called the OFSEP database, where you can find the data for more than 80,000 of patients with MS. So we selected patients that have discontinued an high-efficacy therapies after the age of 50s, and that were stable for at least 2 years. And we matched them to other people that have the same characteristics, but that have continued their high-efficacy therapies. And we made an analysis to determine the time to first relapse. It was the main outcome of our studies in both groups.
And which high efficacy therapies were these patients in the cohorts on?
So there were 3 different treatments. There was the natalizumab, the fingolimod therapies, and also anti-CD20. So it was both rituximab and ocrelizumab. But ocrelizumab is a more recent anti-CD20. So the majority of patients with MS treated with anti-CD20 in our cohort were under rituximab.
Mm-hmm. Now, I know the question is asking whether or not patients taking off of therapy relapse. How long did you follow the patients for to obtain that data? And in general, in clinical practice, when would you expect something like that to happen if you're looking for it? A year, 15 months, 20 months?
It's a good question. I think the answer is different according to the type, the subtypes of high-efficacy therapy that you are looking at. So in younger patients, you expect an increase in relapse rate or even a rebound in disease activity in about 2 to 6 months after the discontinuation, for example, of natalizumab or fingolimod. And there is not many data about discontinuation of anti-CD20 therapies, but you probably have to follow patients with MS for a very long time after the discontinuation of anti-CD20 therapies, also because they have clearly different mechanisms of action.
Right, right. And how long were these patients followed for this result?
So I think that the median follow-up after treatment discontinuations was about 2 years in the studies. So I think it's a good follow-up time for the discontinuation of natalizumab or fingolimod, but it would be very interesting to have some complementary data with a longer follow-up for the questions of the discontinuation of anti-CD20.
Right. Tell us about your results.
The main results of the study is that the time to first relapse was significantly decreased after discontinuation of natalizumab, fingolimod, and anti-CD20 compared to the continuation of these high-efficacy therapies. But the more interesting results of the study was that the result was very different according to the high-efficacy therapies that you stopped, and the time to first relapse was very decreased after discontinuation of natalizumab or fingolimod, but not after the discontinuation of anti-CD20, probably related to the different mechanisms of actions of these treatments.
Wow, that's very interesting. Can you remind us of the mechanisms and the importance and the role they play in multiple sclerosis?
Okay, so for fingolimod and natalizumab, the treatments act on immune cells trafficking. So with these kinds of treatments, the lymphocytes won't pass the blood-brain barrier to go to the CNS, but with the anti-CD20, you will have a depletion. They will deplete B cells. So it's a very different mechanisms of actions. And for example, when you stop fingolimod or natalizumab, you will have a few weeks later, around 4 to 8 weeks for fingolimod, and after 8 weeks after discontinuation of natalizumab, you will have an increase of the lymphocytes, and they will come again to the CNS. Whereas anti-CD20 will deplete B cells for months and months, and so the immune reconstitutions will take a very long time.
Yeah, so it's a shorter turnaround time for the natalizumab and the fingolimod with discontinuation, which actually makes sense in terms of the results. Now, how would you translate this to the bedside and seeing patients in the office? Because there are many patients who might want to stop a particular medication because of the side effects. And how would you counsel a patient like this? We need more time and more studies, but would we, if someone wouldn't prefer the natalizumab or the fingolimod, would we stop it and make sure they're on an anti-CD20 or transfer to a medium efficacy treatment? How would a neurologist tackle that question and dilemma in real time?
Now we have many data about discontinuation on fingolimod and natalizumab because we have all these studies in younger patients that finally have the same kind of conclusions of our studies in older patients. So it's very risky to stop these kinds of medications without switching to another therapy. There is also lots of study in younger patients about the best therapeutic strategy after discontinuation of natalizumab and fingolimod, and probably that relay therapy with anti-CD20 is a good strategy. So we can imagine that in older patients, it could be also the good strategy, but we don't have data in this subpopulation to date. And I think also that we need more data about the therapeutic strategy after anti-CD20 discontinuation, because as I explained before, our follow-up duration is quite short in our study for anti-CD20. And clearly we need to have other study with a longer follow-up to be sure that we can discontinue this kind of treatment without switching, for example, to a medium efficacy therapies after stopping anti-CD20. So if I have to resume that, we need to switch to another therapy for patients after discontinuation of natalizumab and fingolimod, and probably anti-CD20 is a good option. And for on discontinuation of anti-CD20, probably we need more data and studies with longer follow-up.
Yeah, that makes a lot of sense. Dr. Kerbrat, what is next for you in this topic?
I think that this point that I just discussed before about studies with longer follow-up durations after stopping anti-CD20 is an important question. So can we definitely stop anti-CD20 in older patients without relay therapy, or is it reasonable to start a median efficacy therapy? So we have an ongoing project. So it's the next step, I think.
Dr. Kerbrat, thank you so much for joining us on the podcast today. We are looking forward to your future work, and I'm excited for our listeners to dive deep into your paper.
Thank you very much for inviting me. And I want to thank first all the investigators in the OFCEP database, so the French national database. I want also to thank my co-authors, and in particular Guillaume Jouvenot, Guilhem Courbon, and Nicolas Colonga.
This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. This is Dr. Cynthia Armand. Thank you for listening.